cancer patients, either before, during, or after therapy. And then I sat down and I thought, well, really, neurocognition is part of what we call central sensitivity syndrome. So I thought, well, let's actually talk about the broader topic. And today I'm giving you guys a real presentation. This is not watered down. This is the real thing. I've given this talk internationally. So you're getting all of our information here. Let's begin by talking about survivorship. And when we talk about survivors, what we know is that survivorship is a state of increased risk. And you're at increased risk for a shorter survival. And there are a number of reasons. One is that you can get second cancers as a result of the same risk factors that caused the first cancer. And there's also an increased risk of death from non-cancer related causes in head and neck cancer survivors. There is also an increased risk for what we call early frailty. That is what we call the early aging phenotype. And there are a number of biologic markers to that. And then the third risk category is symptom burden. Head and neck cancer survivors are at increased risk for symptoms, whether that's local regional symptoms such as difficulty swallowing or systemic symptoms. And what we're going to be talking about today is the increased risk for systemic symptoms in head and neck cancer survivors. These other topics are all great topics, but this is what we're going to be talking about. So we're going to start by talking about systemic symptoms and sickness behavior. And many of you are familiar with this. What we know is that numerous diseases evoke a stereotypic response in the body. And the purpose of that response is to aid in recovery. And in the short term, that's very beneficial. In the long term, it's maladaptive and harmful. So when we're talking about chronic fatigue or chronic cognitive problems as a result of cancer and its treatment, we are talking about long-term maladaptive physiologic processes that have caused those particular systemic symptoms. Now, there are a lot of words that are used to describe sickness syndrome and sickness behaviors. And by the way, originally the work was on sickness behaviors, and we're all really familiar with sickness behaviors. We may not think of it that way, but we are, because everyone who's had a flu knows all about sickness behaviors. What happens when you get a flu? You get sleepy, you don't want to get out of bed, you don't want to get up and do anything, you have a markedly decreased activity level, and you really don't want to eat, you just want to be a bump on a log and sit there, right? And why do we get that way? Well, your body is conserving energy, it's conserving its strength, it's responding to the illness and saying, look, shut everything down and allow the body to heal. So, and sickness behaviors, we understand individually. They were initially studied in animals, but more recently, other words have been used to describe these symptoms. And one of the commonly used phrases is what's called central sensitivity syndrome. And it's really become much more recognized since COVID. And this, what people call long haul COVID, are really the central sensitivity symptoms associated with COVID survivors. So what we're talking about today when we talk about central sensitivity syndrome in our head and neck cancer patients is very similar to what we now know of as long haul COVID. Now, so what causes central sensitivity syndrome or sickness behaviors? Well, when you become ill, whether it's a virus or whether it's a bacterial infection or whether you're in the burn unit from a really bad burn, or whether you have cancer and received cancer therapy, your body, your peripheral body, needs to talk to your brain, right? Because your brain coordinates a bunch of different responses. It coordinates the endocrine system and the immune system and the central and peripheral nervous systems. So how does the body communicate to the brain? Well, one of the ways that it communicates to the brain is it produces these chemicals that we call cytokines. And those cytokines get into the system and they are able to signal the brain. And these cytokines are inflammatory mediators, act as immune system to central nervous system signaling molecules. Now, unfortunately, what can happen is the brain itself can become inflamed. And when the brain itself becomes inflamed and these cytokines get into or signal the central nervous system, specific types of nerves, you don't need to know the types, the microglial cells and the astrocytes can be activated, and they produce more cytokines and neurotoxins. And so the brain can become inflamed. We call that neuroinflammation. And when you have a lot of inflammation going on in the body for a long time, and it's the peripheral body is signaling the brain, and the brain becomes inflamed and it remains inflamed for a long time, you can get irreversible changes in the neural structures, the structures in the brain. And this can result in chronic symptoms and functional deficits. And this is a picture of that. And this is what happens in our cancer patients. This is one of my favorite pictures of what we're talking about. So we have somebody who has cancer. And so they have tumor cells. Here are tumor cells right there. And in their body, they also have immune cells. And they're getting surgery, radiation, and chemotherapy. And all of that results in inflammation and the release of these signaling molecules that get into the bloodstream and go to the brain. And here's your brain. And here are two important types of nerve cells, microglial cells and astrocytes. You don't need to know that. But when this brain becomes inflamed, you get a bunch of symptoms. Cognitive dysfunction, fatigue, depression, sleep disruption. All of these are the sickness behaviors we're talking about. And one of the things that we know is stress can make all of this worse. So today I was asked to talk specifically about cognitive dysfunction, but the reality is it's not isolated. It's part of this syndrome. So we're actually going to talk about the syndrome. And so when we look at this syndrome, we can break it, what are the things that cause this, these chemicals to be released into the system and cause changes or symptoms, neurologic associated symptoms? Well, cancer by itself can do that. I'm going to show you some data that shows that. Treatment can cause these chemicals to be released and psychological stress. And we tend to break the symptoms down, these neurobehavioral symptoms down into 4 categories. Cognition, which would be memory loss, problems with inattention, decreased alertness, disorientation. Those are just a few. You can also get abnormalities in mood, such as depression, anxiety, irritability, and aggression. You can get what we call the neurovegetative symptoms like fatigue, slowed behavior, decreased appetite, and then what we consider somatic symptoms such as pain and GI distress such as chronic nausea. Now, we're going to talk about half a dozen of these common symptoms that we see in this syndrome. And as I've shown you, they all have this, it's the same mechanism. So we're going to start by talking about central or inflammatory pain, which many of you experience. And I think it's really important to understand, we normally think of pain like you prick your finger and with a needle, and you feel pain at the site where you were pricked. But you can have a different type of pain, what we call central pain or inflammatory pain. And that's actually a disturbance in the pain processing. And so what that is it is due to an amplification of an augmentation of how your brain normally processes pain, so that pain, instead of being just where you prick your finger, the pain can be more diffuse and it's multifocal. So a lot of patients will say, I hurt all over. How many of you have experienced that sense? You say, it's not like I pricked my finger and I hurt in my finger. I hurt all over. And you sit there and go, wait a minute, I didn't do anything to my elbows, my knees, my joints, my muscles. Why do I hurt at these sites? It's diffuse and it's not in a distribution of known tissue damage. And central pain is associated with other symptoms. What other symptoms is it associated? All the symptoms we just talked about. And you can actually be genetically predisposed to get central pain. And the interesting thing is environmental stressors can also increase central pain. One of the most commonly understood types of central pain is fibromyalgia. And the pain that our head and neck cancer patients have, the central pain that patients have, is very similar to fibromyalgia. And if you look at, this is the diagnostic criteria for fibromyalgia. And when I say that pain is associated with other symptoms, well, just take a look at the other symptoms that they look for in their fibromyalgia patients. Loss of energy, stiffness, altered sleep, depression, problems with memory, anxiety. These are the same symptoms we're talking about in our head and neck cancer patients and the survivors. These are also the same symptoms we're talking about in patients who have long haul COVID. So what does it tell you? It tells you that when you have a profound inflammatory insult, something that causes, and all of you've had mucositis, right? Every one of you've had mucositis. Mucositis is inflammation, and it's a profound inflammation, and every one of you knows that. And that it's a protracted inflammation. It's not like a little flu that you have for 3 days. You have that inflammation in your mouth and your throat for weeks and sometimes months. And so what happens is those chemicals are released into the system, they're carried to the brain becomes inflamed, and you develop these systemic symptoms. And it's very similar for fibromyalgia, it's very similar for long haul COVID. Okay, so one piece of or one type of symptom that patients can get is this central pain, this widespread pain. Another thing that patients can get as a result of this systemic inflammation is neurocognitive deficits. And this is a study that we conducted here at Vanderbilt. It was a prospective study where we wanted to look at neurocognitive function in our head and neck cancer patients. And we did neuropsychiatric testing. We asked patients to fill out questionnaires, and then we actually assessed them for delirium. And we did that before treatment, during treatment, and after treatment. And here is one of the things that we found, which was very interesting, was that 47% of patients had neurocognitive impairment before they started their chemoradiation, 47%. And that is purely from the inflammation associated from the cancer. Then we looked at the long-term neurocognitive function, and we found that there were long-term declines in neurocognitive functioning in a small percentage of patients, for any one of these types of neurocognitive dysfunction, and all of these are different types of neurocognitive dysfunction, whether it's attention, concentration, executive function, language, verbal learning, verbal memory, processing speed. You can see that the numbers, the decline is, the percent of patients who have decline is small, but it's there. And it's manifested in different ways. We can also see that 9% of patients during treatment had delirium at some point during their treatment. And if you asked patients whether or not they had any symptoms of delirium at some point, 30% of patients said that they did. If you actually ask caregivers, we did a study on caregivers, and that from that same study, we asked the caregivers whether or not they noticed symptoms of delirium and other abnormal neurocognitive symptoms in patients during the time of their therapy and for the next couple of months thereafter. We asked caregivers about this, and this is what the caregivers said, which was intriguing. This is the frequency of these abnormal behaviors. Nighttime behaviors, meaning difficulty, sundowning, depression or dysphoria, decreased alertness, inattention, apathy or indifference, anxiety, agitation, irritability. So family members were noticing many of these neuropsychiatric symptoms. And so that, and for many of the caregivers, that was very distressing. In addition to cognitive problems, we know that cognitive problems relate very closely with depression and anxiety. And this is another study that we conducted where we looked at the rate of depression and anxiety in our head and neck cancer patients. And if you look at, and this is at one time point, you can see 35% of patients endorsed depression and 23% endorsed anxiety. So anxiety and depression, again, which can be caused by inflammation or associated with inflammation, very frequent in our patients. And the thing that's really important to note, these are all quality of life indicators over here. So physical quality of life, social quality of life, emotional quality of life, functional quality of life. And what happens is if you have depression or anxiety, your quality of life drops. So if you don't have anxiety or depression, the scores for your physical, social, emotional, and functional well-being are higher than if you have depression or anxiety. And that makes sense, right? So our head and neck cancer patients have a high rate of anxiety and depression, and anxiety and depression is associated with decreased quality of life. Okay, what's the next? I showed you that picture with all of the symptoms that are caused by this inflammation that can be caused either by the tumor or by treatment. Here's one that I think every one of you knows about: fatigue. I don't think there's any head and neck cancer patient that I know that hasn't had fatigue due to their treatment, their tumor and their treatment. And I think what's really important to know is not all fatigue is the same, right? There are peripheral and central mechanism or fatigue. So if you go run a marathon, you are going to be fatigued, but you're going to go home, take a very long nap, get a good night's sleep, and you're going to feel better the next day. But central fatigue, this is the fatigue that we're talking about that's associated with the brain inflammation, the neuroinflammation, that patients like head and neck cancer patients get. That's a totally different beast. Central fatigue doesn't go away when you take a nap. And it can be very limiting, very limiting. And there are a variety of different fatigue syndromes, and you don't need to know all of these syndromes, but it's really important to know that fatigue is a part of this systemic symptom complex. What else? Thermal discomfort. Many of our patients will be cold when other people aren't cold. I don't know how many of you on the call have that symptom, or may have sweats, or may be hot when other people are not. So there's an intolerance to cold or heat. We don't know why that happens. We know that it is a central phenomenon, meaning it's related to the effects of inflammation on the brain, but there have been very few studies on this. We know that patients with head and neck cancer have disordered sleep. In one study, this insomnia was seen in over 60% of head and neck cancer patients a year out from therapy. There's also, we know, an increase in obstructive sleep apnea, even in patients who aren't the big bulky guys with the big neck that we think of when we think of obstructive sleep apnea. And treating that obstructive sleep apnea, by the way, improves inflammation. We know that head and neck cancer patients also have muscle wasting and decreased physical function. And I'm not going to go into all of these, the details here. But the thing to realize is that most of the weight loss that head and neck cancer patients experience when they lose weight during treatment, it's lean body mass. It is not fat. It's the muscle. And that body mass loss, that lean muscle mass loss, is associated with inflammation, and it results in decrease in physical activity. And we all know that, right? I don't know too many head and neck cancer patients that don't have at least some sense of, hey, look, I feel weaker and my physical functioning, it declines after treatment. And hopefully it recovers, but not in all patients. And, I know I'm a bugaboo about not losing weight, but this is why. This is a study looking at 175 head and neck cancer patients who underwent primary or adjuvant radiation. And they followed these patients. And what they found was that a significant percent of patients lost muscle mass. And if they lost a significant amount of muscle mass to the point where they had what we call sarcopenia, which is a very low, which is a markedly reduced muscle mass, that there was a decrease in local regional control, overall survival, and disease-specific survival. That means that their survival from their cancer was decreased if they lost a lot of muscle mass. So that's why for those of you who I yelled, ranted, and raved at, that was why. So, you know, we look at this and we say, okay, you've just gone over a bunch of symptoms that comprise this syndrome. And many of you have had these symptoms. So, you know, I'm not just whistling Dixie. So the question becomes, how frequently do we see this in our head and neck cancer survivors? Is this uncommon? And the answer is no, it's not uncommon. We did this study looking at chronic and unremitting symptoms in long-term survivors of head and neck cancer. And it was a sample of 100 head and neck cancer patients who are a minimum of a year out from therapy. And we looked at the prevalence of chronic systemic symptoms. So you will recognize these items. These are the same questions on the questionnaire that I ask you guys to fill out when you come into clinic. Unexplained fatigue. Fatigue limits activity. Problems with sleep. Falling asleep, staying asleep, sweating, cold, hot, memory problems, joint muscle aches, sadness, and anxiety. All the symptoms we have just been talking about. And so this gray area, these are the patients who a year out didn't have any of these, had no fatigue or, you know, no cold intolerance or no heat intolerance. The black were the patients who had mild symptoms. Yeah, not bad. They'd say, you know, it's a 1 or a 2. The red are the patients who had moderate to severe symptoms. And as you can see, none of these symptoms were moderate to severe in a high percentage of patients. But a not insignificant percentage of patients a year out had these systemic symptoms. So let's take a look at a couple of these in a little bit more detail. Fatigue. Unexplained fatigue was seen was mild in 21% of patients and moderate to severe in 20% of patients. And fatigue that limits activity was similar. And here's a quote from a patient. Your family and your friends just don't understand. They think that just because you don't have cancer any longer, you should be back to the way things were before. They just don't understand why you stay so tired. And I know some of you can relate to that. Prevalence of sleep disturbance. 26% of patients had mild problems falling asleep. 8%, it was moderate to severe. 26% said they had mild problems staying asleep. It was 21%, it was moderate to severe. Okay, so what did the patients say? Their insights were, it's hard to understand why my body can't do the thing that should be the easiest, sleep. Sometimes I wake up feeling worse than I did before I went to sleep. Now that is discouraging. Thermal discomfort. Sweating. 12% of patients say it's a mild problem. 8% said it's moderate to severe. Cold intolerance. 28% of patients said it was mild. 21% said it was moderate to severe. Heat intolerance. 26% of patients had mild problems with that. But for 4% of patients, it was moderate to severe. Insights from the patients. I've had to turn down jobs because I just couldn't go out in the cold. Prevalence of neurocognitive dysfunction. 25% of patients had mild symptoms over a year out. In 20% of the patients, it was moderate to severe. Widespread pain, 20% of 7% of patients mild, 23% of patients moderate to severe. Insight, even I don't understand why I hurt everywhere. My cancer was in my throat. Mood disorders, 23% of patients had mild depressive symptoms, 8% moderate to severe. Anxiety, 26% of patients had mild symptoms, 11% moderate to severe. And there were some unique items that we looked at, which using a new scale that we're in the process of validating. Percent with, this is restlessness, no interest in people, distractibility, irritability, decreased motivation, tension, and slowed movement. This is percentage with mild complaints, percentage with moderate to severe complaints. And here's quality of life. Now, when you look at quality of life, this is when people score 7 out of 10, you say, what's your quality of life on a scale of 0 to 10, with 10 being great and 0 being horrible? 7 to 10 is good quality of life. If you're between 4 and 7, you know, it's a bit of a struggle, and less than 4, it's not so hot. So you can see that most patients, here's the median, where it's half of patients are above this line. For most patients, quality of life is in the good range. And there's some people where they'll say, hey, look, it's you know, I struggle a little bit. But there are some people down here, luckily it's the minority of patients, but there's some people whose quality of life is just not so great. And you say, well, how does that correlate? Oh, I've left out a slide. You say, how does that correlate with systemic symptoms? And what you'll find is that the quality of life in the patients who have fewer systemic symptoms is better. And the patients who have a lot of systemic symptoms, the quality of life is worse. So what is really important is to recognize that we have a lot of patients who are surviving long term, and chronic systemic symptoms have a substantial impact. And that impact is not only in the symptoms, but its impact on their overall quality of life. So it's not just about, hey, look, I have cognitive dysfunction. It's generally not isolated. These things tend to group. And so it's this whole syndrome and how that syndrome affects patients' quality of life. And so, you know, what I tell healthcare providers is, you know, people will say, well, what can I do? Well, the first thing you have to do is recognize that the problem exists, right? You have to validate that for patients, right? As healthcare providers, we need to say, yes, you're entitled to fatigue. Yes, you're entitled to have neurocognitive problems. You are entitled to widespread pain. These are things we recognize are long-term or late manifestations. And yes, for most patients, it's going to be mild. But for some patients, these symptoms are severe and function limiting. And then we as providers need to be very aggressive about doing what we can to manage symptoms. And there's some symptoms we just don't have great drugs for, but we have to do the best we can. And so, you know, we have to recognize these problems, we have to manage them to the best of our ability, and we need to validate them for patients. So, you know, one of the common things I hear patients who I didn't treat who will come in for an opinion about, you know, how to manage their late effects, one of the things they'll say is, oh, thank goodness you're telling me that this is real, because I was beginning to think I was nuts. Everybody thought I was nuts. And it's nice to hear that this is real and this is not in my brain. And actually it is in their brain, but it's real in their brain, right? It is not, you know, some manifestation of somebody who is, you know, trying to get off work. It's real. And so for me, it's really important that providers understand these things. It's hard to educate them. And from the standpoint of patients, you know, sometimes it can be hard to stand up for yourself, but you need to, because this is real. And I think COVID long haul has made it much easier for me to explain to not only patients, but other providers what's going on with our patients and why they're having symptoms. So I am going to end there because I've talked